So the doctors say, you're perfectly fine. They get a report from the sleep lab saying they had 0 awakenings. And meanwhile, they might have been waking up 50 plus times an hour like I was. One technician's and doctor's quote unquote normal sleep can be another's really, really bad sleep. The difference wasn't my sleep, it was the lab's scoring protocol. Hey everybody, so in this second of a 3, or I haven't decided yet, 4-part series on navigating the medical system, I'll talk about what it was like for me to get a UARS diagnosis and why it's so tricky and so difficult for so many of us to get a diagnosis to begin with. And I'll walk through some sleep lab results from a home sleep study, a WatchPAT study, and 2 polysomnographies, one where they found UARS and another where they completely missed it. So I was actually among the lucky few people who found a sleep lab pretty much right away that was able to diagnose UARS. And I'll tell you about my experience later, but there's so many people that I've heard of, whether on forums or talking to them, they go to a sleep lab and then they get sent home with no answers whatsoever. So the doctors say, you're perfectly fine. They get a report from the sleep lab saying they had 0 awakenings. And meanwhile, they might have been waking up 50 plus times an hour like I was. And this kind of false negative, i.e., a diagnostic test saying you don't have whatever we're testing for, whereas in reality you actually do, can be really dangerous, because you're sending people out on a wild goose chase then to figure out, okay, if that's not it, what is the actual issue? And I think in my case, had I went to the sleep lab and it had popped up negative, I don't think I would have went back to another sleep specialist or another sleep lab to do this again to figure out, okay, are you sure? I would have trusted the doctors. At least until, maybe years later, I pursued all the other treatments and nothing worked. And maybe I found information online, additional information, pieced the puzzle pieces together to figure out, oh, I actually do have a sleep issue. That test, which I thought was a gold standard, was inaccurate in that case, and I have to do it again. So this is a lot of what this video is about, but what's going on here? And so why is this happening here? Well, the most important thing for a sleep lab to be scoring and measuring when diagnosing upper airway resistance syndrome are so-called respiratory effort-related arousals, or RERAs for short. And what are those? Well, they're essentially brief awakenings that happen when your airway partially collapses, causing your body to shift from deeper sleep into lighter stages of sleep. And why does this happen to begin with? Why does the airway collapse? Well, during deep sleep, and most of you know this already, but your muscles relax, and especially during REM. So your muscles are completely relaxed during REM. And those include muscles that support your airway. So your throat may narrow, your airway may narrow, making it harder to breathe. It becomes like sucking air through a straw. And your brain essentially senses this respiratory effort, the increased effort to breathe, sounds the alarm and wakes you up just enough to breathe again. So that's a RERA. And when this happens, dozens of times per hour, your sleep gets really fragmented. Essentially, another word for your sleep just gets cut up into little bits and chopped up. So you never get a consolidated kind of sleep architecture that's healthy. So going back to the question of why people with UARS are often missed or not diagnosed, the answer is because the sleep labs or technicians aren't scoring or measuring the RERAs, because people with UARS often may only have RERAs, though some may also have apneas and hypopneas, but perhaps not enough of those apneas to really catch attention or to be clinically relevant in the eyes of the technicians and the doctors. And then here we have to back up a bit. What are apneas? What are hypopneas? And why are only these measured or scored oftentimes? And real quickly, because I know a lot of people know this, apneas, hypopneas are essentially long breathing pauses of 10 seconds or more. Technically, they're also a decrease in the amplitude of your breath. But anyways, to count as true apneas, they also have to be linked with significant oxygen desaturations or drops in your oxygen levels. and or cortical arousals from sleep, i.e. when your brain wakes up from deeper to lighter sleep. So these definitions of apneas and hypopneas were originally made to make scoring more standardized and reproducible between technicians, which makes a lot of sense for research and insurance purposes, because if you want to study sleep apnea, which is a condition that's along a spectrum, and you need actual people who are, technicians who are staying up all night monitoring the data coming in from a patient connected to dozens of sensors, you need protocols to essentially standardize how these technicians are scoring this data and evaluating this data, because otherwise you'd just be all over the place, right? And you need that standardization for doctors to make the right call in diagnosing a patient. Now, the problem is, if you have these strict guidelines, well, anybody who falls out of these diagnostic criteria, i.e. patients, and who fall along the spectrum but aren't quite above the threshold for classifying as somebody with sleep apnea or obstructive sleep apnea, then they're essentially missed. They fall through the cracks. Unfortunately, though, for many of us, these diagnostic criteria suck, because in practice, that means essentially if you're not choking for long enough in the sleep lab, that those respiratory events that you're having, they aren't counting as apneas and hypopneas, i.e. they're not counting towards the diagnosis and your ability to get insurance and treatment. So, going back to UARS, well, as we explained, it's primarily driven by RERAs, and those often aren't accompanied by oxygen drops at all. So they're often so short in duration that that they're not going to be classified as apneas and hypopneas, because they could be just a couple seconds long or less. And the actual cortical arousal, so the thing shifting you from deep sleep, is not the oxygen drop, which would happen, yes, if you were choking for a bit longer than a couple seconds, but it is even just the increased effort to breathe. So when your airway collapses partially and you're breathing through, a smaller straw, that your brain is already registering, it's harder to breathe, and immediately wakes you up in order to, again, increase the patency of your airway or the size of your airway. So that's why, people with UARS, they can have completely, quote unquote, normal test results when the sleep labs don't look at RERAs or shorter respiratory effort-related arousals. Now, on some good news is that the diagnostic criteria actually did change at some point. The American Academy of Sleep Medicine, with the International Classification of Sleep Disorders, ICSD, did now include RDI, which includes all types of respiratory events. So apneas, hypopneas, RERAs, central apneas, I wonder, but includes RDI in addition to AHI as a diagnostic criteria for diagnosing obstructive sleep apnea. So for instance, mild OSA can be now classified as either an AHI above 5 or an RDI above 5. So RDI, again, including RERAs. So that's great. But now, not so great news is that still not all sleep labs score RERAs or RDI. So it seems that this the diagnostic criteria hasn't quite trickled through yet, and it makes sense. I mean, medical system is humongous, and people have to be trained on new diagnostic criteria and so on. But it does seem that awareness is growing, and that more labs now report RDI, or as an alternative, sometimes they'll report an overall arousal index. So as more and more labs are just realizing, well, it's very important to just figure out how fragmented is a person's sleep. So they'll be tagging every time a person essentially wakes up and has a cortical arousal, and then correlating that to different reasons of why that arousal was happening, whether that's limb movements or respiratory effort, etc. And so many labs will now be reporting just overall arousal index, which you can then use to get a sense of what your RERAs would be by essentially subtracting your apneas and hypopneas and maybe counting a few for spontaneous arousals. But if you suspect a UARS, you can use that to get an idea, at least, for the number of RERAs that you might be having. But That being said, all of that, still many sleep labs just do not score RERAs, don't know how to, or haven't been trained to do so. And it's good that you ask what is being scored when you go to a sleep lab. But more on that in a minute. Because first I wanted to talk about insurance, because apparently, these diagnostic criteria kind of screwed us over. Because in the US at least, Medicare only recognizes apneas and hypopneas for insurance coverage. So going back to the old AASM criteria of what OSA actually is, and they don't recognize RERAs. And since many private insurers follow Medicare's guidelines in the US, people with UARS often have to pay entirely out of pocket. So that's not great, and that's been my experience, where I've been paying for all my treatments, CPAP, MAD devices, other treatments, surgeries, 9 different surgeries, all of this is added up to tens and tens of thousands of dollars. And it's been a huge burden, and I've read of so many people just delaying their care because of it, or just being financially held back for years. And honestly, that's been my experience, to be quite honest, where I essentially haven't been able to pay down my student loans because I need money in my bank account to, pay for upcoming surgeries. I've been waiting for maxillary expansion, orthodontic treatment, and potentially jaw surgery, and that's very pricey and expensive. Meanwhile, I'm spending like $700 a month on an outrageous premium, because my sleep apnea was considered a pre-existing condition. When I switched jobs, I had to, I had the option of staying on my current insurance and actually get it covered, but I'd have to, increase my premium by a lot, and I chose to do that. But it's just a lot, So yeah, I wish the Medicare and other insurance providers were forced to change their criteria there. But yeah, so I don't have a lot of answers on the insurance coverage question because I haven't succeeded in that myself. But there are a lot of people in the forums who do have inputs and help on this. There are things that people have been able to get covered where you think, this isn't, no way insurance will cover it. It's worth a shot. And one thing I will say is worth working with your doctor to get a obstructive sleep apnea diagnosis, and not to, highlight it necessarily as UARS, because actually UARS is classified as obstructive sleep apnea in the AASM. So it's OSA is essentially on the spectrum, and UARS is considered on the lower end of the severity of that spectrum, though that's not just debatable, but false in my mind. I think UARS can be even more debilitating than OSA. Yes, in any case, that's the way it's classified. So you should have OSA written on your diagnosis, and that will raise less questions whether or not your provider, will cover RERAs, apneas, hypopneas, or whatever their system is. If it says OSA, then a lot of times you would just get waved through, and that's the way it should be. That's not insurance fraud. That's just, the way the system should work. And yeah, so that's that on insurance. So now finally getting into the details of getting a diagnosis. What's the process like? Well, for me, this is the way it was. And if it is for you as well, the first referral, you'll probably first get a home sleep test. And these can be really convenient, etc. But most of them, except for a few, like devices like WatchPAT or the Sunrise, they won't detect these subtle arousals that you have with UARS. So they might completely miss that you have sleep disordered breathing. And that's what happened in my first home sleep test. It only reported apneas and hypopneas, and did that even poorly. So my AHI was like around 2, which is technically normal, but it raised some red flags with the doctor. So they referred me to a full sleep study, which finally revealed, the full problem. So if you suspect UARS, just make sure that your home sleep test, if you do get one, is a device that can detect RERAs or flow limitations, like the WatchPAT or Sunrise, or that your doctor is aware that if they give you a different home sleep test, that even if it turns out negative, that you would still like a full polysomnography, i.e. a sleep lab. And here, just to show you, what WatchPAT results might look like. So here's an example from one of my studies where the respiratory disturbance index, the RDI, i.e. the total breathing related arousals per hour, was 21 overall and 35 during REM sleep, so much higher during REM. So according to National Institutes of Health definitions, that's considered moderate overall, but severe during REM sleep. So interestingly, it was much worse during REM. And you can see here my oxygen levels barely drop. So just 5 desaturations of 4% or more all night. And that's pretty normal with UARS, constant cortical arousals, but no real major oxygen dips. Also helpful is the report, shows sleep position. And for many people, sleep disordered breathing is worse on the back because gravity is essentially pulling the tongue and soft tissue backward. Makes sense, narrowing the airway. And that wasn't obvious in my WatchPAT, but a later sleep endoscopy showed that my airway almost completely collapsed on my back and improved when I slept on my side. So just something else interesting in the report that can be helpful to determine if you have positional sleep apnea. But regardless of whether you get a home test or not, a full polysomnography in a certified sleep lab is the gold standard, and you're going to want to get one of those at some point, and before and perhaps after treatment, or to titrate your treatment. But again, the sleep lab should really be scoring, or needs to be scoring, RERAs, or at the very least arousal index. And I'd argue this is important even if you have obstructive sleep apnea, because treating obstructive sleep apnea, I've seen this in the forums quite a lot, where people have a CPAP but have residual issues and tiredness. And this may be because they're treating frank apneas and hypopneas, but they're not treating these smaller, more subtle respiratory effort-related arousals. So when you get a referral, ask specifically the sleep lab and doctor if they do report overall arousal index and RERAs. And in my first diagnostic study, this was in 2014, they did score RERAs, and my RDI was 35. I had almost 200 RERAs that night, even though my apnea index was 0. And then what happened after is I was prescribed a CPAP, and they conducted a so-called titration study where they tested the CPAP under different pressures in the sleep lab to see which pressure was going to help the most, or where I needed to be at what level. And you can see that the CPAP brought down the arousal index here. But interestingly, during the number of spontaneous arousals went up, meaning the arousals from sleep that weren't due to respiratory effort increased. Or they classify as spontaneous arousals, arousals they can't really figure out why it happened, or they might have happened due to non-clinically relevant reasons. But for me, this might have been because I wasn't tolerating the CPAP yet, so my body just wasn't used to the CPAP and this pressure, and I was waking up. Or it could have been differences in how the technician scored RERAs from the previous technician. So in other words, there's a possibility that, weirdly enough, the CPAP actually wasn't helping much, and that these spontaneous arousals are still RERAs, and it's really just the difference in how the technician scored during those 2 different nights, which, I'm just mentioning that's a possibility, and it's to highlight how frustrating it can be to have this kind of diagnostic test that's just not 100% accurate, and doesn't always give you the answers. And speaking of frustrating experiences, I had an experience of a lab that completely missed my sleep disordered breathing. And this happened a few years after my first diagnosis, when I was living in Turkey. And there was a sleep lab where the first time I went there, they actually did score RERAs. And my AHI then was still only around 5, but my RDI was close to 90 an hour, meaning I was having a respiratory event almost every 40 seconds. I wasn't sleeping at all, essentially. And my condition, I guess, had gotten worse over the last few years. And that's when I started, exploring surgical options, etc. But anyways, then to the frustrating part, a couple of years later, I went again back for a follow-up study, same lab in Turkey, in Istanbul, same setup, but this time they didn't score RERAs, didn't even look at them, And the doctor, after the sleep lab was done, said everything was fine and that I really shouldn't be thinking about sleep. It's all in my head, and that maybe I should go see a psychiatrist, a psychologist. Good advice. Everybody should probably see a psychologist at some point. But honestly, that sucked. I mean, the difference wasn't my sleep. It was the lab's scoring protocol. And the reason I know I wasn't magically sleeping better is because, A, I was still super exhausted, but B, also in another sleep test, just a couple months later, again, my sleep was horrendous. So it's just to show that, one technician's and doctor's quote unquote normal sleep can be another's really, really bad sleep, just depending on how they're scoring and looking at the data coming in. But still, it was really strange to me that the same doctor who had my records from previously just was blindly going by the technician's report and assumed that was all there was to the story. It's almost like the doctor had never been trained in recognizing the importance of cortical arousals or sleep fragmentation or more subtle respiratory effort-related arousals, and just went by whatever the technician was putting down on this report. And, this definitely wasn't the only time I had a doctor essentially gaslight me like that. It's happened a lot of times. And every time it does happen, and I read this happening to a lot of other people on the forums and so on, it's super demotivating because you always pin your hopes just a little bit consciously or subconsciously on, a new doctor, and you're waiting for months maybe to see them. And when they don't come through but actively work against you, that's just sad and really disappointing. And yeah, it comes down again to the medical system just not being up to par and being able to really deal with UARS because there's just so little awareness around it. So that's it for video number 2. Key takeaway is if you suspect that you have upper airway resistance syndrome, just make sure that your sleep study or the device, whether that's a WatchPAT or Sunrise or home sleep study, whatever, make sure it measures respiratory effort related arousals, or at least that it reports an overall arousal index. So the number of times that your brain is waking up and the reflection of the overall fragmentation of your sleep. So that's important. And even if you have obstructive sleep apnea, I'd argue that's important because you may be treating your apneas and hypopneas. So the more obvious respiratory disturbances, but you may be missing the RERAs altogether. So these more subtle restrictions in airflow that may be causing you to still be tired, even though your CPAP, BiPAP, or whatever you're using is on the surface treating your obstructive sleep apnea. So anyways, I hope this has been helpful. And if you've gone through this process or dealt with insurance issues, especially around UARS, please share your experience in the comments. I'm sure it will be really helpful to others navigating this oftentimes very confusing and demotivating process. And in the next part, I'd like to go over some diagnostic options, and what's worked for me, what's not worked for me, essentially diagnostics besides the sleep lab that help you pinpoint where the issue is and what treatments might be effective. So thanks, and talk to you soon.